Mr. Chairman, ladies and gentlemen, thank you for giving us the opportunity of presenting our data on clinical complexity today. My thanks to my co-authors. From this study is that local site of surgery complexity exists, can be quantified, and is currently unreported. The absence of this evidence is not evidence of our whilst we have plenty of data and papers defining patients by systemic comorbidity, the same cannot be said for local complexity at the site of surgery, in particular arthritis pattern or magnitude of implant surgery undertaken. This is reflected to some extent by the MJR dataset. Our complexity grading is essentially a 2x2 matrix based on the presence or absence of local and systemic complexity, providing 4 groups ranging from no complexity in the top left to both local and systemic complexity in the bottom right. The assessor needs to ask 2 yes-no questions to determine allocation into the group. Responses from these 2 questions effectively allocate patients groups. Between 2008 and 10, we further defined local and systemic complexity by literature review and repeated case discussions within the specialist. The study then looked at a cohort of patients entered onto the database prospectively between 2010 and 2018. Once the complexity score had been added to the preoperative assessment database, entry was by specialist need. Databases were interrogated and then merged with other data sets, with key outcome measures being operating time, length of stay, and our cohort consisted of 1,943 patients, with the largest group being no complexity and the smallest group having the combined local and systemic complexity. We noted subtle differences in age, gender, and BMI, which is the potential topic. In terms of key outcome parameters, we noted statistically significant differences between the combined local and systemic complexity and no complexity group in operating time, and also in terms of length of stay. There was also differences that were statistically different in the local complexity group in terms of length of stay. Looking at mortality, there are even larger differences between the least and most complex groups, and differences again between the combination of local and systemic complexity. We conclude that the current system focuses heavily on systemic complexities only. Patients with combined local and systemic complications do have the poorest outcomes, with the combination seemingly causing detrimental effects. This has implications for both practice and performance metrics. We feel that our methodology is both malleable and open to further study, so we should not be blind to clinical complexity. Thank you very much. That's end of dictation. Thanks.